Hello again, everybody. We are going to talk about bradyarrhythmias here, and bradyarrhythmias are part of a wider classification of diseases known as arrhythmias, which encompass a lot of different things. I've divided these up into the bradyarrhythmias, which are arrhythmias less than 60 beats per minute, the tachyarrhythmias, which are greater than 100 beats per minute, and then flutters and fibrillations, which have some characteristic appearances on EKG, and then premature contractions and pre-excitations. So in common, the bradyarrhythmias all have a heart rate of less than 60 beats per minute. Now there are cases where bradyarrhythmia, or I should say bradycardia, is normal. So for instance, in somebody who is a runner or a high endurance trained athlete, they can have a resting heart rate of 45-50 beats per minute, and that's completely normal. But for the general population, any heart rate of less than 60 beats per minute is abnormal. And that's just considered bradycardia. When there is an arrhythmia leading to the bradycardia, that's where we call it bradyarrhythmia. The most important factor to note in any patient with bradyarrhythmia, and really the most important factor to note whenever a patient comes into the hospital, is whether the patient is stable. So we can ask things like, how's their blood pressure? If for some reason they have a very low blood pressure, then we consider the patient to be less stable, of course. Is there chest pain present? Was there at any point a loss of consciousness? And then what about their extremities and their general appearance? Is there paleness? Are their extremities cold? Have they lost consciousness lately, or have they fallen down lately? Any patient who is experiencing acute symptoms should receive therapy, but there are patients who will do therapy on even if they don't have symptoms. It really just depends on the clinical case and the setting. The mainstay of therapy for the bradyarrhythmias is atropine. Atropine stimulates, increases the heart rate, and so that is the mainstay of therapy for the bradyarrhythmias, but we're going to see that with different bradyarrhythmias, we're going to approach it a little bit differently. As far as long-term, if there is something, if we need to treat them long-term, we don't just keep giving them atropine. There are things that we can do, such as external or internal pacing. So these are the arrhythmias that we're going to talk about. We're going to talk about sinus bradycardia, which isn't technically an arrhythmia. It's just a slow heart rate. We're going to talk about the AV nodal blocks, and then we're going to talk about the bundle branch blocks. So sinus bradycardia is not an arrhythmia. What it is just a slow heart rate, and this can be normal or it can be abnormal. When it's abnormal is when it has certain symptoms that are associated with low perfusion. So you can imagine that if your heart is not beating enough, and you have symptoms that your brain or your extremities are not getting enough oxygen, then the two of those are linked. So if the patient doesn't have any symptoms and they just have a heart rate of 55, they have sinus bradycardia, that's fine. You don't need to treat that. But if they have symptoms, like for instance, if they have dizziness, if they have disorientation or loss of consciousness, or if they say they're lightheaded, or if they have a low blood pressure, then you need to treat them. So sinus bradycardia, when you look on the EKG, it will just be a normal EKG that's just slow. And I'm assuming you know what a normal EKG looks like. That's step 1 material. So there's many different causes of sinus bradycardia, and I'm not going to cover each of these and why they cause bradycardia. Excessive vagal tone, carotid sinus pressure, hypothyroidism, adverse effects or overdoses of opiates or benzodiazepines or heroin, hypothermia, seizures, ischemic heart disease, and acute MI. So because there are so many different causes of sinus bradycardia, the history is not necessarily the most useful because it can happen to virtually anyone. Even it can happen in normal circumstances. The symptoms, if sinus bradycardia is causing symptoms, if you're getting symptoms out of the slow heart rate, what they're going to be is lightheadedness, confusion, loss of consciousness, or dizziness. And what all these are just the symptoms of not getting enough blood to the brain. On physical exam, of course, you're going to note that their heart rate will be less than 60, and that will be linked with hypotension. But it doesn't have to be. So if you see a patient who has
a heart rate of less than 60 and they're presenting with any kind of neurologic symptoms that may present decreased perfusion to the brain, so lightheadedness, confusion, dizziness, then you need to get an EKG on these patients. So low heart rate with symptoms is a clear prompt for an EKG. On EKG, you'll see a normal EKG with just a slow heart rate, and I'll show you what that looks like. And the way you're going to treat this, of course, if the patient has symptoms, which presuming they came in because they have symptoms, if they don't have symptoms, you don't treat it. If they have symptoms, what you want to do is you want to establish IV access, give them IV atropine until the symptoms have resolved. And if it hasn't resolved with the IV atropine, what you can do is you can initiate a transcutaneous pacer. And that's not really fun for the patient because it's this machine that pumps the heart from outside the ribs, and it's somewhat painful for them. So we prefer to use the IV atropine. But if that doesn't work and we're not getting anywhere with it, then we can go ahead with transcutaneous pacing until we can consult the cardiologist. Past transcutaneous pacing, you don't need to know anything about that. That's beyond the scope of the USMLE. So the EKG is not really remarkable other than you have a normal sinus rhythm and just a slow heart rate. So here we have a normal sinus rhythm. Here's another one. This is even slower. And here's one more. Okay. So that's about it for as far as sinus bradycardia. As far as AV nodal block, what you need to know here is that this is a conduction disorder due to interruption between the SA node and the AV node. Okay, so I want you to pay attention to this because this is really important that you know how the heart conduction system works, because for all of the arrhythmias, you're going to have a disruption of this system. So we have an SA node, and the SA node sits here sort of on the inferior vena or superior vena cava in the right atrium. And that don't worry about all the other stuff. Just worry about SA node, AV node, and the bundle branches. So SA node conducts to the AV node, which sits on the border between the atrium and the ventricle, and then that conducts down the interventricular septum down along through the ventricles. So when you have an AV nodal block, what you have is a block somewhere between the sinoatrial node, the SA node, and the AV node. And what happens is that block slows down your conduction between the SA node and the AV node. Well, what happens when you're conducting between the SA node and the AV node? That is atrial depolarization. That's when your atria are contracting. And so between the atria contracting and the ventricles contracting, that's what's going to be disrupted in AV nodal blocks. So your atria contracting is your P wave, and your ventricles contracting is your QRS complex. So if you have an AV nodal block, you will have an increased distance between your P wave and your QRS complex, or particularly your R point. So what we call that then is just an elongation of the PR interval. The time between the atrial polarization and the ventricular depolarization is elongated. And so that's the definition of an AV nodal block. And this can be normal in some patients, but if it is acquired, if it's new in a patient, then it's usually due to ischemia. And all that happens is part of the heart tissue, part of the conduction system, has become ischemic, and now there's a block in the way between the SA node and the AV node. And so the time between when the atria depolarize and when the ventricles depolarize is elongated. And that's the otherwise known as elongation of the PR interval. So again, in any bradyarrhythmia, if there are symptoms from this arrhythmia, just like in sinus bradycardia, if there are symptoms, they're going to be your typical symptoms of hypoperfusion: dizziness, syncope, disorientation, lightheadedness, hypotension. So there's 4 different kinds of AV nodal blocks, and the only way you're going to be able to tell these apart are on EKG. So you have a patient that comes in, they have a slow heart rate, and they have symptoms that look like hypoperfusion, you get an EKG. The only way you're going to tell what the arrhythmia is by looking at the rhythm, by looking at the EKG. So the only way you're going to make this diagnosis is with EKG. So let's look at some of the EKGs. Okay, so this is basically what I just talked about. Alright, so here's the first degree AV block. So this can be normal in some patients, and what this is it's just an elongated PR interval. So the normal PR interval from the middle of the P wave to the middle of the QRS complex, the peak of the QRS complex, is 0.2 seconds, so one big box, the length of one big box. Here we have a PR interval of 0.28 seconds. Now in all first degree AV blocks, the only abnormal thing is that we have an elongated PR interval. That's all. That's the only thing that's abnormal. Otherwise, and they have bradycardia. Otherwise, there's nothing wrong with this patient. This is usually congenital and it doesn't require treatment. Here's another one. So here you have a PR interval and it's more than one big box. So it's just an elongated PR interval. Nothing else wrong with this patient. This does not require treatment. Here's another one. Here's your P wave. Here's your QRS. Doesn't require treatment. First degree AV block doesn't require treatment. Now a second degree AV block is different. What a second degree AV block is where you have an elongated PR interval, but with each progressive heartbeat, that PR interval becomes more elongated and more elongated and more elongated. And then at some point, you have a P wave that doesn't have a corresponding QRS complex. So let's look here. You have a P wave and a QRS complex. That's not even an elongated PR interval. That's less than one big box. Now you have a P wave and a QRS interval. That's elongated. That's about a little more than one big red box. And now you have, on this beat, you have a PR interval that's 1.5 big boxes. So you can see here a progression of elongation of the PR interval. And now here, after the T wave here, you have a P wave and no corresponding QRS complexes. So you've dropped a beat. And that is a second degree AV block, or otherwise known, this is a Mobitz type 1. There's two different kinds of second degree AV blocks. The Mobitz type 1 is the progressively elongating PR interval. Okay, here's another one, just for your viewing pleasure. And another one. So you see here again this progressive elongation here, and then here's the drop right here. Sometimes it helps to look down at the bottom because your leads up here don't really show you a long enough strip to see the drop. But here's your drop right here. So you got four beats with an elongating PR interval and then a dropped QRS. Now, Mobitz type 2, so this is also second degree, but this is Mobitz type 2. It's similar to Mobitz type 1 in that you do have a dropped QRS complex, but you don't have an elongating PR interval. You have what appears here to be a normal PR interval, and then all of a sudden, a P wave without a QRS complex. So, P wave, normal PR complex, or normal PR interval, P wave, normal PR interval, P wave, dropped QRS complex. P wave, dropped QRS complex. P wave, normal QRS complex. Okay? Here's another one. So we don't have the elongation in Mobitz type 2, second degree. So that's the difference. Second degree Mobitz type 1, you have a progressive elongation, the PR interval, and then a drop. Second degree Mobitz type 2, you have a normal PR interval, and then suddenly a drop. So here you have it again. This one looks like there might be a little bit of AFib present. Okay, now third degree AV block is the worst symptomatically, because with third degree AV block, there's no correlation between the P wave and the QRS complex. Now with the other three, at least when we had a P wave, we would normally get a QRS complex at least at some point. With third-degree AV block, the P waves and the QRS complexes just don't correspond with one another at all. So here you have a P wave here and a QRS complex 2 big boxes later. Here you have a P wave with a QRS complex about half a big box later. Here you have a P wave and really no QRS complex until about 4 boxes later. So you can tell that this is abnormal. So there's no correspondence whatsoever between the P wave and the QRS complex. Here's another one. And here's another one. Okay, so which ones require treatment? Well, remember that first degree is just simple PR prolongation. With every P wave, you had a QRS wave, but it was just a PR prolongation. That was the only thing that was abnormal. You don't need any treatment for that. That's generally congenital in most people. So no worries with first degree AV nodal block. Now, in second degree block, you only need treatment if there's symptoms. So for second degree type 1. So if there's a progressive PR prolongation followed by the QRS drop, the second degree Mobitz type 1, you're only going to need treatment if there's symptoms. If you see an EKG and you see second degree Mobitz type 1 block, but the patient doesn't have symptoms, let's say they're in for something else, then you're not going to need to treat this patient if they don't have symptoms of hypoperfusion. It might be good to tell the patient that they have a second degree Mobitz type 1 block and educate them, but unless they're having hypoperfusion symptoms, you don't need to do anything about it at that point. So remember, second degree type 1 is the progressive PR prolongation followed by, at some point, a QRS drop. And no treatment is required unless there is hypoperfusion symptoms, and if there are, then you would give them IV atropine. With the second degree Mobitz type 2 block, where you have just the random drops of QRS, those patients, you will need to give them a pacemaker. So second degree type 2, PR prolongation with random QRS drops, they need internal pacing. And the same thing with the third degree AV nodal blocks, where there's no association between the P wave and the QRS complex. They will also need internal pacing. So the bundle branch blocks are usually an adverse effect or a sign of some kind of ischemia. So what a bundle branch block is, what I want you to think is to think back to that picture that I showed you of the conduction system. And remember where most heart attacks occur. They occur on ventricular tissue. So what a bundle branch block is it's a block on the bundle that conducts to the ventricle, allowing ventricular contraction, allowing ventricular depolarization. So if you have an ischemic part of your heart, if you have a little scar of ischemia, then you can have a little bit of a block on that bundle branch, and then the electricity is just going to have to go around it. And that's a bundle branch block. It generally doesn't result in any symptoms, but you'll see it on an EKG. And if you see an EKG on a patient and you see a right or left bundle branch block, you can usually say this patient has coronary artery disease or this patient has had a heart attack. But this is rarely symptomatic, but it's good to know what it is because it can tell you something about the patient's history. So very rarely symptomatic. So how do you tell a left from a right bundle branch block? And this is really, really important. Remember what your precordial leads are. S1 goes right kind of on the sternum. S2 goes on the other side. And then S3, S4, S5, and S6 go to the left all the way down to your mid-axial line. So the S4, S5, and S6 leads are more to the left of the heart, and the S1, S2, and S3 leads are more to the right of the heart. So if you see abnormalities, and of course these are going to be QRS abnormalities, why? Because this is bundle branch blocks, and what do the bundle branches do? They conduct through the ventricles. So you're going to see your abnormality on QRS complexes. If you see abnormalities on S1, S2, S3, and sometimes even S4, that's on the right side. So that will be a right bundle branch block, and I'll show you what the abnormality is. You'll never forget it. If you see the abnormalities on S4, S5, S6, and sometimes even on S3, that's a left-sided bundle branch block. So here is a left bundle or a right bundle branch block. And look at the abnormality here. Look at this QRS wave. Look at the one on V5 and look at the one on V2. Notice that little dimple there? That's your bundle branch block. And what all that is the electricity conducting through the ventricle, and it hits a point of scar tissue and it has to take a little detour. And it causes this little dimple right here. You see it here, here. You see it kind of here. And so you see it most on V2. So that's probably the V2, where the V2 lead is closest to where the ischemic tissue is. But because you see it most on V1, V2, V3, and really not too much on V4, you can say this is a right-sided bundle branch block because this is on the right-sided leads. Here's another one. This one's even more outstanding. So here you see it almost goes all the way back down to baseline on V2. And you see it on, I don't know if that's, no, that's not V5. That's just V2. So here's another one that's over V2, but it's on V1, V2, V3. So this is, again, another right bundle branch block. Here's another one. This one's a little bit more inconspicuous, but this one's, again, it's over V2. They don't all happen like that over V2. But this is another right bundle branch block because it's happening over V1 through V3 or V4. You're not seeing it over V5 or V6. Now we'll compare that to the left bundle branch block, and you can see here that we have a normal, albeit maybe a little bit wide of a QRS complex, and V4 and V5 are where we have that dimple. See here, see the little dimple here on V5? You see an even bigger dimple on V4. This is a left bundle branch block. It's on the left-sided precordial leads. Here's another one. It's over V5 and V6. So this is a little bit more lateral than the other one. And then here's another one. So this one's the most inconspicuous. This one's kind of up in the air because it's over V3 and V4. So I called this a left bundle branch block because you can see the dimple a little bit more in V4 than you can in V3. But on the USMLE, you'll get something pretty clear and obvious. So this is a left bundle branch block. Just look for the little dimple on the precordial leads. And bundle branch blocks, not symptomatic, they don't need treatment. But any kind of bradycardia that is giving you symptoms of hypoperfusion, neurological symptoms of hypoperfusion, IV atropine. That doesn't work, go on to pacemakers. Pacemakers will be required in Mobitz type, in second degree Mobitz type 2 and in third degree AV blocks. And that's it.